hematology consultant at Royal Marsden, and who was heavily involved in myeloma 11 and all the writing up, and now is very heavily involved with IFIT trial too. She will talk to us about non-intensive arm of the newly diagnosed patients. Thank you, Charlotte.
Thank you very much, and thank you for inviting me to speak. I changed my title slightly to be the aims of induction therapy in frailer myeloma patients, because I think we've broadly split into patients who we considered transplant eligible and transplant ineligible, at least in the traditional sense of thinking about that, although QE has made us maybe reassess where we should be placing that line. These are my disclosures. So I was asked to talk about the goals of myeloma therapy, and I'm not really sure that the goals of myeloma therapy are very different for younger and older patients, or frailer and less frail patients. But maybe how we go about achieving them is potentially slightly different. But I think for all patients, what we're really trying to do with initial therapy is induce a deep remission, prolong the duration of that remission, and hope that that leads to a prolonged overall survival for patients. Along the way, we're also trying to manage patients' comorbidities, think about treatment complications that we might have driven by the treatment that we're delivering, maintain patients' quality of life, and improve any symptoms that they might have been experiencing from their initial diagnosis. And so if we put those in any order, I think these are all really key features for patients, but perhaps in the older patients, it's slightly more nuanced and multifactorial, because many more of these will be an issue than in younger patients, for example, who have no comorbidities and experience fewer complications of therapy. And why is it different, or do we know it really is different for patients of increasing age? So this is an analysis we did from data of the myeloma 11 study, which, if you will remember, recruited patients across the whole age spectrum, so had transplant eligible and ineligible patients, and had broadly similar therapies apart from transplant throughout. And you can see that with increasing age decade, there are shorter progression-free survival and overall survival outcomes for patients. But that's all very well. You might say that you would expect an 80-plus-year-old to live for less time than a 50-year-old person. And so we compared that data to the expected life expectancy for each of those age groups. And you can see in the faint yellow line here that the excess mortality in the over 80s is much greater than in younger patients. So the proportion of life years lost is higher in older patients. And whereas QE is largely focused on tumour genetics and the tumour clone driving outcomes, we know that that is also different in older patients. And this is, again, an analysis of data from myeloma 11, where we looked at the relative contribution of ISS stage, performance status, and cytogenetic risk to the outcomes of patients across the decade. And you can see the contribution of cytogenetic risk in green goes down. It's still present, it's still important, but it is less of a feature than other features in the over 80-year-olds, for example. And features that are perhaps more associated with frailty have a greater impact on outcome. We also know that older patients have increased toxicity compared to younger patients, particularly in older trials. So the data at the top is from myeloma 11, showing more cessation due to toxicity in older patients with both the CTD and CRD combinations. But you might think that is now outdated. So if you look at the data from Maya, you can see that although all groups of patients benefited from the addition of daratumumab in terms of outcomes, frail patients had a shorter time in therapy, more treatment-emergent adverse events, more growth factor usage, and a higher rate of treatment discontinuation due to adverse events. So there is still work to do in trying to improve outcomes for the oldest, frailest patients, who make up a very large proportion of the patients we treat routinely. I included this slide partly because this is our guest speaker's PhD that I went to examine in Iceland recently, but mostly because I think it's really important data on the effect of cumulative comorbidities in terms of outcome in myeloma. So if you are older, you are more likely to have more comorbidities, and the more comorbidities you have at any age decreases outcomes, decreases survival for myeloma patients. If you have time, I'd encourage you to delve into the forest plot of all of the different comorbidities, because actually what I think is really interesting is that they're not all equal, and some things that are perhaps counterintuitive, some things have a higher impact on outcome. You can see heart failure, for example, here having a big impact on outcome, but things like rheumatological disease here having less of an impact on outcome. So we need to think carefully when we're collecting comorbidities, how we're integrating that into our expectation for patients. And so frail patients, I would argue, need to have different goals of care because they have different challenges in terms of treatment. And that's because by the accumulation of age, they've accumulated frailty due to senescence of underlying cells, just a normal process of aging. But they've also potentially accumulated different medical conditions, so multi-comorbidities. They've also then had the added impact of their myeloma diagnosis, so frailty from their cancer issue. And then we're going to administer treatment that's going to potentially cause side effects on top of that. And so all of that contributes to a frailty spiral showed here from Gordon Cook's paper a few years ago, which suggests that that background of underlying age, along with the added insults of myeloma and its treatment, really drive that potential impact on patients in terms of frailty. And we also know that this is a group that has largely previously been excluded from clinical trials, both academic studies and industry studies. And potentially that's because there are many domains that we need to think about when we're focused on this group of patients. So not only their comorbidities and performance status, but how many other medications are they taking, and perhaps other elements of geriatric syndromes or other areas of life that they need more support with than our younger patients. And so we've been able to look at frailty in clinical trials, and I know you'll be familiar with this approach. So the use of frailty scores retrospectively from historical studies has been able to divide patients into fit, unfit, and frail groups. And the gold standard approach for that is the IMWG frailty score, which is shown here. And I know everybody is now familiar with this because a large number of people in the room will have delivered this about 8 times per patient for every patient in myeloma 14. So no one is any longer able to tell me that this is not feasible on a large scale in many patients at multiple time points, because you all did it. And we're very grateful for that because we now have lots of data from that study coming out. But in essence, we assess patients' age, their Charlson Comorbidity Index, and then 2 questionnaires of activities of daily living, and the outcome correlates with progression-free and overall survival, but perhaps more importantly, non-hematological toxicity and discontinuation rates that were particularly higher in frail patients. Now, I've told you you're not allowed to complain about it being time-consuming because it was very efficiently performed, but somebody did consider that and therefore came up with the simplified IMWG frailty score, which uses ECOG performance status instead of patient questionnaires and divides patients into frail and non-frail based on that. And this is the initial publication based on data from the first study using that approach. But this study for me is really important. This is a paper published by the Dutch group looking at using the simplified IMWG score instead of the full IMWG score. And you can see that there's a proportion of patients who are misclassified, and the outcomes for the misclassified patients are very different. And so you do get different information from performing the full rather than the abbreviated score. So for me, that means although we have some evolution in terms of scoring systems, the gold standard and the approach we should be using in trials is the IMWG frailty score in full. And so that's helped us to move from this retrospective approach of applying the score to a whole population to really defining the score in patients up front and thinking about different approaches for the different patient groups and adapting therapy for patients based on their frailty. And somebody's briefly shown this data already today, but I just wanted to highlight for those of you who haven't yet seen it, data from the fitness study that was presented at ASH by Gordon Cook this year, which really summarised the first results that we're getting from fitness, which for those of you who aren't taking part is a randomisation between a standard dosing approach for older patients and IMWG frailty score adapted dosing with the induction regimen of ixazomib, lenalidomide and dexamethasone. So in the adaptive dosing approach, patients who were frail had dose reductions of lenalidomide and dexamethasone to 10 and 10 milligrams, and unfit patients 15, 20, and fit patients had full dosing of those agents. There's a second randomization that we don't have data from yet that we'll read out going forward. But this was the initial analysis, which was planned to compare patients who were unfit or frail, initially in terms of early treatment cessation, so stopping treatment early for whatever reason. And the primary comparison showed no difference between the arms, but there is very significant heterogeneity between the unfit group and the frail group, which is shown here. So the unfit group of patients had a very significant benefit from having adapted induction treatment. So a dose adapted based on frailty induction treatment lessened the incidence of early treatment cessation in patients in that intermediate unfit group. Why this was not seen in the frail group, we're trying to understand at the moment and try to explore that. But I think importantly, several other outcomes from the trial also were positive, and this is event-free survival, so defined as progression, death, withdrawal, or toxicities. And you can see that patients who had frailty-adapted dosing, shown in blue, had a longer time to their first event than those patients who had standard dosing. And also, interestingly, the overall survival outcomes for patients within the whole trial who had frailty-adapted dosing was prolonged compared to the patients who had standard dosing, and that appeared to be consistent in the subgroup of patients who were unfit and frail as well. And we're trying to kind of get our heads around all of this data and work out exactly what that means, but I think it broadly tells us that we can deliver frailty-adapted dosing, we can assess patients and deliver dosing in that way. It also tells us we were able to recruit very large numbers of frail patients. About 50% of patients in the trial were classified as frail. And so we have some data to support possible dose modifications for older patients, which I've highlighted here, some based from fitness and some based from expert opinion, that we might want to think about when we're starting patients on induction therapy or relapse therapy, potentially, although there's less data in that space. One of the other things we've learnt is that frailty is a very dynamic and potentially modifiable risk factor. So we can see patients initially classified as unfit becoming fit over time. Also, we can see the opposite, patients starting fit whose performance status deteriorates and the frailty group moves from being fit to unfit or unfit to frail. And when we see this, as is summarized here in the fitness study standard arm only, if it happens early, this suggests an element of disease overlay treatment, removing the impact on the patient and them being able to improve their degree of fitness. Later on, maybe that implies ongoing improvement in function that comes with that removal of the myeloma overlay. And the Dutch, again, have looked at this in terms of predicting overall survival and found that for patients who have a dynamic frailty change, this better predicts overall survival. So if patients' frailty score improves from baseline, that helps us to refine what their likely outcome is going to be. But we focused a bit on how to deliver therapy, but the actual aim of the talk was to think about what is the goal of therapy. And for me, the goal of therapy in older patients is exactly the same as the goal of therapy in younger patients. And that's to induce the deepest possible remissions with MRD negativity as a goal for all of our patients. And that is equally important in older, less fit patients as it is in younger, fitter patients. And I think this is sometimes lost because we often think about MRD-guided strategies or MRD as an outcome in the younger transplant-eligible patients. But this is data from myeloma 11 on the left, showing the outcomes for MRD-negative patients being very much significantly better than those who are MRD-positive. And again, in the MAIA study, so using the DRD combination, for patients who are MRD negative, particularly if that's prolonged, but even if it's a single time point MRD negative assessment, their outcomes are really very much improved compared to MRD positive patients. And that's looking within a single trial. So if you look at individual patients within a single trial, their MRD status will associate with their outcome. But when the FDA was assessing the use of MRD as an endpoint, what they're looking for is not only that individual association, but trial-level association. So if you have more patients who are MRD negative, do you have a better PFS in that study, and can you replicate that and show that correlation across studies? And I just highlight this because I found it interesting watching online that the correlation for transplant-ineligible patients is actually much greater than for transplant-eligible patients. And that's perhaps something that gets lost, but contributed to the consideration of this endpoint in trials by the FDA across both transplant eligible and transplant ineligible patients. And that's important. I want to thank Sally for highlighting this paper to me yesterday. I'm very impressed with how up to date she is because I think it was published last week. But this looks at inducing deeper remissions in patients who it really improves outcomes even in patients with lower physical functioning. So this is an analysis of daratumumab containing trials and patients assessed by patient-reported outcome measures as having low physical function is shown in the top and higher physical functioning shown in the bottom. And you can see that the hazard ratio for benefit from daratumumab is actually even more impressive in those patients with lower physical function than higher physical function, really reinforcing this goal of achieving deep remissions being equally as important in this group of patients. So if we go back to the data from Maya, we can see that patients who achieve MRD negativity on DRD have really amazing outcomes, and some of those outcomes are approaching what we might expect to be the normal life expectancy for people in the population of an age-matched cohort. And that led us to the design for IFIT, which I can only apologise, you're now seeing for about the 4th time today because I shared this slide quite widely before the meeting. But this is the follow-on study from Fitness for older, less fit patients in the UK, which we hopefully will have open by August. And that MRD outcome has really driven the rationale for this. So for patients who achieve MRD negativity with Dara-Lendex, they have excellent outcomes, and potentially the question we should be asking, or we will ask, is what is the duration of therapy that is appropriate for patients? So can we give patients time-limited therapy compared to the Maya approach of continuing therapy to progressive disease? But for patients who are MRD positive, we want to try and augment their response to improve their outcomes, and so we will randomize patients who are either fit or unfit to continuing with Dara-Lendex as per Maya, or switching to immunotherapy, T-cell engaging therapy with Dara-Tec or Dara-Tal for a time-limited duration of 18 months and delivering that therapy at monthly intervals, so trying to reduce the intensity of treatment and giving time-limited therapy to again give patients a period of time off treatment. For frail patients, there are some considerations in the nationwide population about whether those patients would be suitable for T-cell engagers in all cases. And so at the moment, the question in the frail group is to consider the stopping of dexamethasone in the DRD combination. But we're considering for a subgroup of those patients adding in an additional bispecific question to that cohort. So in summary, I think it's really important to think about the goals of care in our older patients, but those goals don't necessarily have to be different. They just need to align with the other medical conditions and other considerations in older patients. For me, stratified medicine in the older patient group needs to focus on frailty and not on genetics. And there are several frailty scores that are published and validated to help us to do this. Importantly, we should be thinking about how frailty is dynamic, how can we improve it, how can we support patients to better tolerate treatment. But for me, trying to achieve the deepest MRD negative remission in patients, even those of an older age, is really important. So I'd like to thank everybody from my clinical group in the Marsden and the ICR, and all of the people who work on the clinical trials that I've mentioned today. Thank you.
Thank you, Charlotte. That was a great talk, and obviously the IFIT study will be very important for our less fit patients. We're going to do the questions at the end.